Welcome to the American Association of Critical Care Nurses Voices in Nursing podcast, exploring critical care nursing through meaningful and inspiring conversations. This episode is brought to you by AACN's Knowledge Assessment Tool, helping educators identify knowledge gaps and educational needs of nurses new to the unit or new to ICU or PCU patient care, with information available at www.aacn.org/Assess New Nurse. Now, here are your hosts, AACN's Chief Clinical Officer, Vicki Good, and Clinical Practice Specialist, Andrea Schmidt.
Welcome to this episode in Voices of Nursing. I am Vicki Good, and I'm joined by my co-host, Andrea Schmidt.
Hi, welcome to today's podcast.
This podcast will focus on the value of acute and critical care nursing. Capturing the financial value of nursing has been difficult, yet it is such an important aspect of the work that we do as nurses. For years, nursing care has really been part of the room charge. The Centers of Medicare and Medicaid Services has recently tried to capture some of the value that nurses bring to the healthcare system through hospital-based core measures, but that still hasn't captured the true value of nurses.
Vicki, I know this project is important to you as well, as you've been a part of this work, and it's very near and dear to your heart. I'm really looking forward to discussing this topic today because I really feel like this proposal for change can really help showcase the core of what nurses are doing while caring for patients and finally giving these acts value, focusing on the positive impacts of nursing care. And with that, today's guest is Dr. Martha Curley and several colleagues in her proposing a new blueprint for change in acute and critical care nursing. So I'd like to start by learning more about Dr. Curley and her long and impactful career in nursing. So could you share a little about yourself with our listeners?
Yeah, thanks, Andrea, and also Vicki. And I'd like to start by thanking AACN for the opportunity to talk about this work. It's been really a labor of love that a small group of us have come together to articulate. And it's really about a blueprint for change in acute and critical care nursing. A change from a perspective of paying attention to the work of nursing from a harm perspective and moving it over to really what drives nurses, what gives nurses joy, and what we do every single day in the lives of our patients and families that truly makes a difference. But as Vicki said, is totally not measured at all within the healthcare system. So I welcome this opportunity to share with your listeners about this work and perhaps challenge them a little bit to get involved with the work, to help us better articulate what we do so we can measure it and then have it acknowledged for the beauty that it is.
Can you share a little bit about your career?
Oh, Jesus, it's been a very long and storied career. So I've been practicing for a very long period of time. And from a perspective of, I started working at the bedside. I was a staff nurse and then became a clinical educator. And then because I wanted to be able to help nurses take care of their patients and families, I ended up with a master's degree with and a clinical nurse specialist, really functioning as a clinical nurse specialist for over 15 years. And then because I wanted to be able to ask and answer clinical questions from a research perspective, I ended up going into a PhD program and now have a PhD in nursing. So really it started at the bedside and the love of nursing and the practice of nursing and really just making a difference for patients and families. And then over time, my career just kind of evolved to the point where now I'm a clinical nurse researcher. I'm a clinical trials and I run big, huge multi-site clinical trials in pediatric critical care. So, you know, when people say to you, nursing has lots of legs, it certainly does. You know, we can do a lot and we might be in one space for a while, but then over time, we just keep growing as individuals. And nursing is such a beautiful profession where we can do what we want to be able to do. Yeah.
Yeah, and I think, Martha, the thing that I most admire about you, because I've interacted with you throughout my career, is the fact that you always have the direct care nurse in mind.
Mhm.
No matter how deep you get into your research, it's always about the direct care nurse. And so I greatly appreciate that.
Yeah, and my research is on nurse-led therapies, really carving out what nurses do that makes a difference in patients and families. And it's critically important. It's really the heart and soul of nursing and really what drives us. And so, it makes me nervous when people move away too far from the bedside. It's all about the bedside and the work of the bedside nurse and how we, over time, can best support that work.
That's great, Martha. And so I take it that your research has led you to looking into creating this blueprint for change in acute and critical care nurses. And so, besides you, can you tell us who all has been involved in this work?
It's really been an eclectic collection of people, to say the least. What happened was that I'm a member of the American Academy of Nursing, and as a critical care nurse, I am a member of the Acute and Critical Care Expert Panel of the Academy. And a group of us who are members of the Academy, who are involved in critical care nursing, we meet at the Academy meetings, and then we meet periodically throughout the year virtually. And during one of these meetings, we were engaged in the conversation really right through the pandemic of just watching, our colleagues really struggle during the pandemic and then continue to struggle thereafter. And as a group, we really became frustrated by the fact that, how can we best help nurses at the bedside and what can we do to better support them? And our conversations evolved into, well, how do we measure the work of nursing, within the acute and critical care environment? And we all ran into a rant and said, the only way that anybody ever measures what we do is through the harm. It's really about what we don't do, not not all the beauty of what we do. And so it was really out of a frustration in the conversations within this group. The group really wanted to do something to support the bedside nurse. And we felt that if we could flip the script and move from a negative framework to a positive framework and really measure the work of nursing, that really makes a difference for patients and families, that at least nurses would have some evidence about how they make a difference for patients and families beyond what they don't do. And so that's how the group came together. And we kind of pulled different people in who were interested in this. It was almost like a snowball effect. But after, a year and a half of thinking and working through the paper, we had 15 people, and I call them the Fab 15, came together and produced this paper that first called attention to what nurses do. So we identified 9 domains of practice that we felt this is the work of nursing, because in order to measure the work of nursing, we had to have a better understanding of really what nurses do. And that's all of what bedside nurses do in acute and critical care. We acknowledged that we couldn't just call attention to the work without calling a little bit of attention to the practice environment. So we identified 4 major pieces of the practice environment that needed to be in place to better support the work of nursing. And then we went through an inventory of all the metrics that currently exist that describe nursing in acute and critical care. And we were blown away that we could not find anything that really reflected the work. It was all about harm. It was all about, did the nurses answer the call light and time? Is the room clean and tidy? And all those things, which are important, but it really doesn't talk about how nurses, create safe, healing environments, how we prevent iatrogenesis, how we form relationships with patients and family that helps them feel well cared for, okay, and how we're vigilant and provide our vigilance and our clinical judgment to intervene when we need to intervene to prevent bad things from happening for patients and families. How we teach patients and families from the moment we interact with them about how they can exist within our environment and how they can learn to self-care and how they can go home and manage patients, and how we do it really by advocating for them, how we collaborate with multiple, professionals, and how we really can work together to really do more than just prevent CAUTI and CLABSI and pressure ulcers and how we're currently measured. So really, it was a group of people coming together, labor of love, caring deeply about the profession, and really wanting to make a change. And that's why we call it a call to action, because enough is enough. As Vicki said, we're part of the room charge, okay? And so when you're looking at, collapsing cost, you can eliminate nurses, but you can, a nurse is not a nurse, not a nurse. We have different levels of knowledge and expertise that is truly matched to the needs of our patients and families. We interact with them in a way that makes them feel valued and well cared for. And we need to start measuring that. And it's a hard thing, but we need to start.
Yeah, and I think, I reflect back on one of our early guests in this series, and it was a patient who had undergone a, very critical illness. And we asked him what meant the most from his nurses, or what does he want nurses to do? And he said, hold my hand.
Right.
Had nothing to do with, preventing CLABSI and CAUTI, although those are scientifically incredibly important things. So as the Fab 15, which I was privileged to be part of that group, which I thank you for that opportunity. How do you imagine reshifting how nursing is measured? Because it's been measured this way for, 200 years now, or however long we've been a profession. So how do we shift that? I mean, that's a huge ask.
When we finished the paper and, we reached agreement on the 9 domains, and we reached agreement on the care environment, and we reached agreement that we weren't measuring things that we ought to measure for nursing. At the end of the paper, it was like, so whose job is this to change this? And so, we were committed to say, all right, whose job? Is it the ANAs? Is it the academies? Is it the regulators? Is it CMS? Whose job it is? And because it's not just one person's job, it's nobody's job. Okay. Mm-hmm. And so what we kind of figured out is that we needed to divide and conquer. So we're moving past that. We're meeting, for example, with consumer groups, with professional groups, professional nursing societies. We're meeting with CMS, Magnet. We're meeting with representations from a whole host of people, the people who regulate us, who accredit us, who pay for us. And we're hopefully going to form a coalition that comes together and starts tackling this, because it's just not one person's problem or one organization's problem. And that's why I think it's been sitting on the shelf for a long period of time, because it's nobody's problem. You can make a dent of it, but it's just so complex and multifactorial that you can throw up your arms and say, okay, we can't change this, but we have to change this. Care at the bedside needs to be acknowledged, rewarded, and respected and measured. And the only time we can change anything is if we call attention to it through measurement. Mm-hmm. And so we are currently going through an inventory of all the measures that currently exist that relate to patient and family outcomes. And we're going to cross-reference them into the 9 domains. And then we're going to put together a new blueprint of this is how you might measure nursing using existing metrics, and then absolutely call attention to where we're not measuring and we should be. And then different people should own different pieces of this. So, we don't want to add any more documentation burden onto nursing at all. We think we can do enough with the electronic health record to re-articulate what we currently have, feed them into the domains, and show how this can be done. So hopefully through coalitions with professional societies, coalitions with people who do measure, and then really bring together some centers of excellence who would engage in demonstration projects to show how this can happen and how we can work with it and how we can move it forward. So it's not just one entity, it's going to be numerous entities. And it's interesting because when we did meet with CMS was very interested in what we had to say. Not one group thus far has met with us and said, oh no, we can't do this, or we don't like this, or everybody wants to do this and they want to help, but we just need to get organized to really make it happen. And when we met with CMS, they were like, show us how, and we'll consider it. And there is a mechanism of how you can, move metrics into CMS. You have to get in queue. You have to, you have to do due diligence. You have to develop the measures, but they're receptive, absolutely receptive. Everyone was.
There are so many things I want to say right now. This is just amazing. And I can't even pick just one. But first, I want to say thank you and to you for even taking the initiative to do this. What's probably just a mountain of work, you and your core group of people, because definitely somebody has to take ownership of it and at least start the process. And it is so good to hear that we're focusing on nursing and that CMS is actually responsive to this. This gives me hope that maybe there will actually be some change. And I just think there is so much power and strength in voice of nursing and what you and your team are doing. And so that leads me to one of my questions, which you and the other authors of this Blueprint's Purpose are really illustrating that critical nature of nursing contribution to overall optimal patient outcomes, not just the elimination, of course, the adverse events. And you had mentioned those 9 domains. So I was wondering if you could share a little bit about or an overview of what those nine domains are.
Yeah, so the 9 domains were really based on ANA's standards and guidelines. Okay, so we just didn't pull these out of the air. Foundational work is there through the ANA, and also foundational through a lot of Patricia Benner's work on novice to expert, because you have to acknowledge that there's expertise within nursing. All right, so every single nurse contributes differently to a patient and family. So the heterogeneity of patients themselves is huge, okay? And it can be very complex. But fundamentally, if you go back to the work of, Florence Nightingale, we create healing environments. We own the environment of care. So we kind of got lost in the safety movement. Is like, we're all about safety. We're also about healing. We're also about controlling the environment so that we can, create such that patients are well nourished, they sleep, they have day-night cycling. We don't screw up their circadian rhythm. So it's really creating a solid healing environment that kind of like supports the whole other, 8 domains, which again starts with the relationship, the caring relationships we have with patients and families as we meet them and come to know them as people. So that's a huge piece. How do we establish, as Vicki said, how do we hold the hands? How do we know when to hold the hand and when not to hold the hand? And as we're holding the hands, we're doing a whole bunch of other things like managing the patient's symptoms. We're providing physical care, and the physical care could be foundational care, and it could be very complex care that needs to be managed by the nurse. And when needed, we provide end-of-life care so that patients feel well cared for. We're always there. We're always watching. We know what patients might be at risk for, and we're ready, to intervene. And as I said, we teach patients and families how to self-care. We collaborate with others, we advocate for them, and we help patients and families transition, from different places within the inpatient environment, but also as they go home. We never take credit for, the patients who can self-manage and go home and feel good about managing themselves, but we should. That's a major patient outcome that we never take credit for. Some patients come and they're readmitted, but how much money can we save if we spend time thinking about how to transition and better support, patients and families? And as they come in, they're pretty much deer in the headlights, depending on what's going on. And because of the care we give them the strength and the knowledge, and we help them figure out how to exist within the environment and how to manage that over time. Never take credit for that, but we should.
So I love how you're pulling this forward, and it really goes back to that equation of the value of the nurse.
Mm-hmm.
So, how do we measure that value of the nurse? I mean, it's easy to measure. I've had 4 infections this month, and this is how much it costs to take care of a patient with an infection. It's a lot harder to measure the value of nursing and how we impact patients on those, subjective type things. So,
Yeah.
how are we going to do this?
Well, even if we start by, instead of counting how many everything that they got that was bad, how about just starting to count how many patients who are at risk, never develop pressure ulcers, never develop caudries and collapses. So it's really the same metric, but you're flipping it. How many we rescued from those events? Value right there. How do we decrease the length of stay because of how we know the patient, advocate for the patient, and get them in and out? So how do we modify length of stay? We have to risk adjust it always, and it's not hard. Within our current capabilities, given the electronic medical record and just flipping the narrative, we can start by just flipping negative, to positive, and take ownership for the things that we currently have and start putting some financial numbers to that. Vicki, you started the session about the financial, value of nursing, but it's about, we can definitely hit payload there, but it's also about the caring part of this. It's how do we articulate and develop measures that really allow patients and families to talk to us about how they were well cared for?
Mm-hmm.
And that speaks a lot to, recommendations that patients and families would have to go have your care done over at that institute because, unbelievably wonderful care that you receive. So, trying to measure those pieces of it, I definitely think we can do that. But we need everyone who touches a patient to be able to, especially bedside nurses, to be able to articulate their value added. And we never give bedside nurses an opportunity to talk about that. So they know, because again, the heterogeneity of patients, we always try to measure everything across the board. All right. But if it doesn't really match what that patient and family needs, it kind of like waters down the measurement process. But if we measure the right stuff in the right patients, and what we need is bedside nurses to articulate that for us, because they know patients, they know their patient populations, they know the difference that they make, and they need voice to be able to talk about that. Yeah. And then the measurement people, like the people who ended up doing PhD in nursing, who are the measurement people, they need to partner, with bedside nurses, help me understand that phenomena and help me design a rapid cycle measurement process to better measure it. And then we can sell it to CMS. We can sell it to Magnet. We can sell it to the Joint Commission of things that this is the nursing dashboard that needs to be measured in every organization. And then you can get to the value.
Well, and I think oftentimes as a nurse, we don't think about the price tag associated with the care that we provide, because we are caring and compassionate. We don't want to worry about the money, but bedside nurses need to understand that financial equation of how we make such a difference to those patients.
Yeah. I mean, um, everyone needs to understand that. Even I remember going to all the trade shows, and I was really into pressure ulcers and taking care of pressure ulcers at the time because I was doing the prone positioning study in kids and how to better manage that. And we need data every time we pull a new dressing off the shelf. What's the difference between this and that, and how are we caring? And that's again, is it going to help us better care for patients? So, we don't need to, every time we pull something down, this is a $10 bill or a $50 bill, but we can start looking at within different diagnostic groups the readmission rates. There are some DRGs that are diagnostic related groups that are associated with a very hefty price tag. And if you start unpacking, the care that's provided to kids, to patients in high risk groups, and really think about how you could expedite their care, you could save thousands off the bottom line. I'm convinced that you can. We just need to be able to start measuring that, where currently we don't.
Martha, I was thinking about something that you said earlier, that CMS has been interested
Mm-hmm.
in this, and other organizations as well, and, how to move forward. Do you have any rough idea of what the next steps might be, or how the bedside nurse would be incorporated into some of these next steps, or planning, if at all, at this stage?
No, absolutely. So our group, we're dividing and conquering. We're writing editorials for different professional nursing journals. In fact, I just finished an editorial for AJAC, American Journal of Critical Care. It will be published as soon as we get the nurse survey through the IRB. We're going to embed within the editorial a QR code that you can go to the nurse survey and tell us about the 9 domains, whether or not you think they are important, how often you practice them, and whether or not you believe that domain would impact patient outcomes. So right out of the gate, within the next several months, that editorial will be published and the QR code would be there. So please take the time to answer the survey and give us some feedback. There's also opportunity to talk about what's not there. So what care is currently provided that you spend a lot of time with that can't fit within the 9 domains. And so we need the validity check from staff nurses. And so right out of the box, that's going to be put into the editorials. And so we're preparing a few in larger professional organizations like the American Journal of Nursing, Nursing 25, AJAC, the Journal of Professional Nursing. So we want to get to the educators as well, because we need the educators to focus on these 9 domains so that they better prepare nurses to care for patients in hospitals.
So, as a direct care nurse, if I'm looking at the 9 domains, is there one that's more important to me than another one?
It depends on your patients. If you go back to the synergy model, the ACN synergy model for practice, what we do depends upon what patients and families need for us to do. And I'm convinced that different patients require different things at different times. And it's through our clinical judgment and our expertise that we better care for patients, always based upon what they need. Okay, so what might be really important in oncology inpatient care might be very different than in neurology, might be very different in urology. So it's really looking at your practice, and nurses need expertise in all 9 domains, but what is more or less important would depend upon their patients and families. And I think that's also been a little bit of a rub because, we know nurses are not nurses. Everyone has different levels of expertise based upon the needs of the patient. But when we measure the same thing across the board. And hopefully this model will give people another opportunity to say, well, I work in X, Y, and Z, and these domains are more important in my patient population than those. So, yeah, take it and play with it and think about it and help us fine tune it.
It truly represents that, nursing is not one size fits all. So I really think that, excuse me, this is a great approach to take and get their input and buy-in. And so I feel like this is extremely meaningful work. And what is the most meaningful part of this project for you? And what gives you hope about how this can impact the future of nursing?
You asked me earlier about my history. I've been a nurse for a very long period of time. It started at the bedside, and now I'm a clinical trialist. But my heart and soul has always been on standing at the bedside, taking care of patients and families. And it breaks my heart to think about, leaving the profession, retiring out of the profession, and leaving it in the same state that I found it. And I think this work really has allowed a group of us to come together and talk about what's important, what's meaningful, and really at least given a whole bunch of people food for thought about how to change things. Because it's all up to everybody as individuals to change it. But collectively, we're going to have to come together and work together to make this change happen if we really want to be able to show the world the value of nursing.
Yeah, and Martha, I think one thing that we didn't call out at the beginning, but I want to call out now is this article is available to anyone. Many articles are gated and you can only get to it if you're a subscriber, but this one is open access, so anybody can download this article. Can you remind our readers exactly how to find the article?
It's all of the listeners here hopefully are members of AACN. They could go into the editorial that we're writing, and it will be right there and downloadable. But currently, it's all you have to do is just Google and anything. Just Google Curley Blueprint Acute and Critical Care, and boom, it's there. All right, and Blueprint for Change, Call for Action. Just go into Google. You'll see it. You can click on it. As Vicki says, it's open access. Anybody anywhere can get this, and we wanted it so that anybody could get it anywhere, so that you didn't have to have a library card, or access into anyone's repository to pull this. So Google it. You can pull it down off the internet, and it's right there.
And I just want to provide some meaningful recognition for Martha on that, because there is a cost associated to doing that. And Martha did pick up that cost to make that available to every single nurse, which demonstrates your passion for this subject and the passion for the work. So we want to thank you for sharing all of this with our audience and your tremendous work and your tremendous passion for this.
Thank you. Thank you so much. It's really been, a work. It's really been a labor of love for all of us to put this work out. And it's not finished yet. We're not going to have it sit on the shelf. It's going to be finished.
No, and that's has been your byline since we started. This will not sit on a shelf, and you have made that come true.
I love that.
I just want to thank our audience for joining us for this episode, and we welcome any of your feedback on this episode and suggestions for future episodes. You can send that feedback to podcasts@aacn.org. Thank you, and until next time.
Thank you.
Thank you for listening to the American Association of Critical Care Nurses Voices in Nursing podcast, proudly sponsored by AACN's Knowledge Assessment Tool, helping educators identify knowledge gaps and educational needs of nurses new to the unit or new to ICU or PCU patient care, with information available at www.aacn.org. www.aacn.org/assess new nurse.